Good morning, everyone. My name is Monsef Ibrahim Karbouch. I'm Assistant Lecturer of Ophthalmology at Alexandria University. So a 26-year-old male who presented with repaired small scleral full-thickness wound in the past week, clear lens, uncorrected visual active 0.7. The CT showed intraocular foreign body and refused lens extraction, which was offered as a procedure in combined phaco-vitrectomy for the removal of the foreign body, and he came to me. So this is an ultra-wide field photo of this patient. We can see that with the blue arrow, the foreign body is a metallic wire, a localized area of detachment was in red, incidental finding break superior temporally, and in the yellow arrow probably representing the area of impact of the foreign body. We're not sure about that. So our decision was to go for lens sparing vitrectomy. So properly inserting the trocars. You can see the lens is completely clear. After core vitrectomy, I started inducing the PVD. Some surgeons prefer to wait more than 2 weeks after the trauma for the spontaneous PVD, but I'd rather to go early for the fear of the increase of the retinal detachment and the more damage by the foreign body. Sometimes in the PVD, induction is tricky, especially in this young patient, but with good machines and patience, it can be easily done. So completing, of course, the PVD to freely remove the foreign body from its attachment to the retina, and also avoiding hitting the lens in any manipulation inside the globe. We want to keep it as clear as crystal. Shaving not to the farthest periphery, as we said earlier. Now freeing completely the foreign body from its attachment. Now the next part is in slow motion to show you what I've done. I inserted the dormibuscular forceps from the sclerotomy and grasping the foreign body, not from the middle, just from the tip, elevating it away from the retina. Now adjusting with the endolight to have its concavity with the convexity of the lens, and slowly grasping it away from the sclerotomy to avoid hitting the lens. And you can see the lens is kept completely clear as we're removing the foreign body and we safely preserve the lens. Now completing the vitrectomy and doing the endolaser for the area damage and the breaks. And of course, not of course, but I decided to leave the patient on non-expansile concentration with SF6 for the fear of the retinal detachment, which was present localized in this part preoperatively. And I reached the periphery without hitting the lens, thankfully. Now the patient came the first week post-operative with this picture. The classical feathery posterior subcapsular, totally, I cannot see the fundus at that moment. The patient was totally unsatisfied. I reassured the patient, and he came the next week, same picture again. The patient was getting angry. So after 6 weeks, I started to see the fundus, and you can see the globe occupying, the SF6 occupying just less than 1/3 of the vitreous cavity. The retina is flat, laser is also scarred, and the breaks are sealed. And what about the lens at this moment? The lens completely cleared spontaneously without no intervention. You can see here there's the residual level of the air bubble still present in 6 weeks and in 7 weeks. And the patient at this moment could see uncorrectedly 0.8 and could read freely without the need and any glasses, and he was completely satisfied. So my take-home message is just, if you can spare the lens, please spare it. It's not a necessary step in every case of vitrectomy. Thank you so much.
Thank you, Thomas.